Good morning, I'm Julie Kalkbrenner, and I would like to thank you all for joining us today. We have a program today with our Lurie Children's Heart Center, where Dr. Sedaghat will be talking about syncope. So we would like to let Dr. Sedaghat present his material, and then we will have time for questions at the end. So please feel free to type questions in the question box on the right side of your screen. At this time, I would like to introduce you to Dr. Sedaghat. There we go. Let's see, are you able to, let's see. All right, here we go. I'm able to turn right over to you.
Nice. Okay. Julie, can you see this screen?
Yes.
Perfect. All right, good morning, everyone. Thank you for the introduction, Julie, and thank you for having me here today to give the opportunity to give this talk. My talk will be about syncope and initial evaluation of a patient presenting to an outpatient office for syncope. The goals, objectives of today's talk will be to define syncope in the pediatric population, go over the differential diagnosis of pediatric syncope, recognize the red flags in regards to when to do further testing and refer, and hopefully get comfortable evaluating this common problem in an outpatient setting. Due to time restraints, and we will not be talking about treatment of neurocardiogenic syncope and cardiac syncope. These are great talks for future venues, and we will be not talking about POTS, but again, this will be our afternoon or later presentation, so a plug for them. So the definition of syncope, I think, is very important to understand. The actual definition is a sudden, brief loss of consciousness associated with a loss of postural muscle tone due to poor cerebral blood flow, and again, followed by spontaneous recovery. So you have to have an actual loss of consciousness where you are not going to be able to remember or know what's going on during this period, and a loss of postural muscle tone, so you will not be able to stand up unless someone is holding you. So they have to meet this actual criteria to have had a syncopal episode. Many times when we are seeing someone in clinic for what we think is syncope evaluation, when you get the history, you actually see that they really did not have a true syncopal episode. They got close to it. They had some of the preceding warning symptoms. They felt dizzy, they felt nauseous, they were sweaty, they felt their vision going blurry, but either it resolved or they sat down. But by definition, they didn't actually lose postural tone. They were standing up the whole time, or they remember the whole event. They didn't have any loss of consciousness. This is a common, just outpatient, but also in acute visits, so 1 to 3% of ER visits. About 1/3 of the population will have a syncopal episode at some point, and about 15% will experience syncope before 21 years of age. It is definitely more common in females, especially between 15 to 19 years of age. And for those who do have a syncopal episode, about more than half of them will have more than one episode. It is a very common reason where we do see patients, about 15% of our referrals. So the challenging thing in pediatric syncope is that there are no clear guidelines, and mainly comes to because the differential diagnosis varies between adults and children. The older you get, the more likely you are at risk for having cardiac syncope. While this is typically not the case in pediatrics, you can bet that if someone my age were to present an ER for my first syncopal episode, they would be ordering labs, doing an EKG, probably referring me to a cardiologist to look at my coronaries. This is, again, not going to be high concern in pediatrics. Most of the causes are going to be benign. That being said, syncope can be a concerning sign or symptom of a serious or dangerous underlying cardiac problem. And the goal of this talk will be hopefully to determine when this is concerned to do further testing or referral. When a patient has a syncopal episode, it is a very scary episode for them and their family. I mean, they or their parents think that there is seriously something underlying wrong, that they are going to die or something bad is going to happen. So it is a real life scary experience that patients and parents feel. Even in the medical community, we are all afraid of not missing something serious. So the balance comes out, how much do we do not to miss something? Many times we do an unnecessary costed workup just to reassure families or make sure we're not missing anything. But in pediatrics, unless there is some concerning findings, this high or expensive cost of workup will usually have a low diagnostic yield. So what should we do in regards to when someone shows up in our office with a syncopal episode? Do we just start with basic vital signs? Should everyone get an electrocardiogram? Do we do blood work? Do we image everyone's head? Do we do an ultrasound of everyone's heart? So these are kind of the questions that your history and physical exam, of course, will guide. In addition to which we'll talk about as far as doing an appropriate history and physical exam, in my opinion, it is very reasonable to do orthostatic vital signs, which I'll talk about in a little bit, and to do a baseline ECG in most patients. So these are just a few cases where I just want us to think about it, and we'll come back and discuss these at the end. So first one is a 15-year-old female who had 2 syncopal episodes over the last 4 months. One occurred while she was taking a shower in the morning, and the other one occurred at school as she was standing to leave. All episodes were preceded by lightheadedness, nausea, and tunnel vision. 13-year-old male with no significant past medical history who reports having 1 episode of syncope while running mile for gym, and then 2 near syncopal episodes while he was doing suicides for football practice. He did report those days were hot and he was not very well hydrated. A 12-year-old male, again with no significant past history, who had a syncopal episode after he finished running a cross-country practice. He denied any issues while running and actually reports he did a really good job. How about 1 minute after the episode, after he stopped, he passed out. And then secondly is a 16-year-old female who has had numerous syncopal episodes over the last few months to the point where she can't keep a track of it. None of these have been witnessed. She reports that for these, she believes that she's been out for a long time, typically 10 minutes. She's never injured herself during any of these episodes. So we'll come back to these scenarios at the end while we talk through evaluation of syncope. So the differential diagnosis is very helpful. That leads us kind of what we are concerned about or not. So the most common cause, about 3/4 of the patients in pediatric syncope will have neurally mediated or neurocardiogenic syncope. We as a medical community have done a poor job naming it, so there's interchangeable names: autonomic dysfunction, autonomic syncope, neurally mediated, neurocardiogenic, reflex, simple faint. These are all the same mechanism, which we'll discuss. About 10% we might not get an answer, and they'll have resolution of their syncopal episode. 3% are cardiac, which we'll come back to. These are the things where we'll make sure we don't miss. Psychiatric psychogenic is about 2%, but I feel that likely is maybe underestimated. It is very important to tease this out and make sure we're not missing a psychiatric condition in patients, because for these patients, if they are not already followed by psychiatrists or therapists or counselors, very important to refer them. These patients with psychiatric psychogenic syncope, their history will be very challenging and vague. They really will have a hard time explaining something to you, likely because, again, their syncope is not real. Their stories just don't make sense. They seem kind of preposterous, and kind of the mechanism of syncope that they say usually, with no injury, it just doesn't make sense from that perspective. Now, outside of cardiac, of course, neurologic seizure specifically is something which we don't want to miss. Again, you'll have some kind of consistent findings with the neuro exam or history. And more rare entities such as metabolic, environmental. I know a lot of times hypoglycemia is something that is listed. True definition of hypoglycemia is, I would say, very uncommon in someone who does not have diabetes. Many times, poor diet and hydration will lead to these symptoms, which are kind of more neurocardiogenic. But again, true hypoglycemia, I would say, is pretty rare. So the appropriate evaluation for someone coming to your office, as you can see, I have it in bold because it is the most important aspect, is the history, appropriate vital signs, good physical exam, standard ECG is strongly recommended, and of course, identifying the red flags. In most children with cardiac syncope, one of these aspects, if there's a red flag, will help diagnose or identify it. So the history, again, is the most important aspect. That being said, this can be the most challenging aspect because their stories can be hard to put together. They are very time consuming, and not to be mean, but they are kind of sometimes painful to hear when they're all over the place. This is very challenging where we are all very busy in our clinics, and when I do see a patient with syncope, I know I am going to be behind in my clinic schedule, but I think it's very important to spend that initial time to get the important details. Get the information as much as possible from the patient. Of course, you can use the parents and guardians to recollect or say what happened when they were actually passed out, but really try to tease it out as much as from the patient. And as we discussed before, make sure, did they really have syncope, or was it just pre-syncope that got close to it? I found it very not useful when I just asked the patient to describe the episode. It really is helpful to walk them through the episode, because if you just ask them what happened, they will be all over the place. So I start out with, what were you even doing the day before, the night before? What time did you go to sleep? Anything off with how you felt? What time did you wake up on the day of the event? Before it happened, what had you exactly had to eat or drink? Before the episode, the last 5-10 minutes, what were you doing? Were you sitting down? Were you standing? And what did you feel just before you passed out? And of course, the episode, if they truly had a syncopal episode, this is not something they can recall. So this is where you can get information from parents or bystanders. How many times have they had these events? Sometimes if someone has numerous events, again, it can be kind of cumbersome to get the episode, but sometimes you can get a pattern where it's more often in the morning or more often after activity. Did they injure themselves? And then again, how did you feel after the episode? Were you back to your regular self, or was something off or different? Outside of the daily episodes, helpful to ask them, do they have routine or daily or occasional orthostatic symptoms? When they stand up, do they feel dizzy? Did they have their vision go blurry? It is supportive in this aspect. Get a good diet history. Don't just ask him, do you eat breakfast, lunch every day? Ask him specifically what they eat. Some people, when you ask them what they had for breakfast, they say they had some candy bar, or for their lunch, yeah, I had a sandwich. Did you eat your sandwich? No, I took 2 bites and then didn't eat the rest. Get a good fluid intake. Ask them and try to get exactly how much they drink, specifically in the morning and the first half of the day. What did you have in the morning before you left for school? Okay, was orange juice. How much was it? Was it a small glass, a large glass? Did you drink it all? Do you drink caffeinated drinks? Caffeine has counterproductive measures where it increases your heart rate and is a diuretic, so you actually urinate more than you take in. So do you drink, even many teenagers don't consider iced coffee, iced tea, Starbucks drinks caffeinated, so asking exactly what they are drinking. And how many times do you urinate? In someone that is well hydrated, outside of their first morning void, usually a good sign of hydration if they urinate 2 times at school and then 2 to 3 times after school at home. So in regards to the history, what are the red flags you're looking for? Exertional syncope is obviously a very big flag. Now, I really try to differentiate and ask them specifically, what were you doing at the time of exercise? If I ask a child, did you pass out during exercise? This to them can be in the middle of exercise or even 5-10 minutes after I finished exercising. So passing out in the middle of exercise, of course, is not normal. But many times after you finish an exertional event, cross country and so on, and your blood vessels are dilated, you come to a sudden standstill, you're not exercising, you get the same mechanism as neurocardiogenic syncope, where you can get a sudden pooling of blood to your legs, and that can cause syncope, where again, that situation, in my opinion, is less concerning. So ask him, was it during exercise or more after you stopped exercising? Cross country is very classic, where they run this big race and they come to a standstill in a shaded area drinking water and they get this sudden pooling and boom, they pass out. Cheer also, where they're frequently doing a lot of intermittent lifting, squatting, and then they stand still, where you set you up for the scenario. Was it precipitated by loud noise or motion? An alarm clock, a fire alarm happened and then you suddenly dropped. This is concerning for long QT, ventricular arrhythmias. Did you have palpitations or chest pain before the episode? This can be sometimes challenging. Many patients, in my opinion, who do have neurocardiogenic syncope will complain that something feels off in their heart that wasn't beating right before they passed out. Did they have no warning signs or few warning signs? I was just standing there and then boom, I dropped. I didn't even feel anything before that happened. And since neurocardiogenic syncope is the most common cause, any history that does not seem classic with that should kind of be a concerning history or red flag. And now, if anyone has an underlying heart disease, whether it's congenital or acquired, of course, they are at higher risk for having cardiac syncope, and these patients are typically followed by cardiology. But also, if you have some underlying systemic disease that can predispose you to cardiac comorbidities, lupus, malignancy, clotting disorders. Family history, I really try to stick to the first and second degree relatives, parents, siblings, aunts, uncles, grandparents. Not to say you have to ignore everything else, but many times parents get off to a tangent where they do not even know how these people that they're listing are related to them. Now, it's simple if someone has a known history of congenital heart disease, very early coronary artery disease, known arrhythmias like long QT syndrome, but I really try to ask about other things. Was there a sudden death under someone 40 or 50 years of age? Did they die while they were sleeping? Is there a family of stillbirth? Unexplained or unusual death, someone who knew how to swim that drowned, a single person car accident that resulted in death, we don't really know what happened. And in regards to cardiomyopathies, not everyone might know that, so I like to kind of use the words they have a thick or enlarged heart or a history of heart failure. Now, in regards to your physical exam, it is not standard guidelines to do orthostatic vital signs in someone. I think it is helpful. And in cardiology clinic, we typically do them because we are seeing patients who do have more severe or prolonged syncope. It does take time. It does take experience for your staff to know how to do them appropriately. Typically, we have them lay down for 5 minutes, and then we have them stand up and do it at the 1 and 3 minute mark. More than the heart rate and blood pressure, I think if they have symptoms is very helpful because it shows you that, again, they're experiencing these symptoms that is supportive to your diagnosis. That being said, having symptoms during orthostatic vital signs is supportive, but again, if there are red flags in other area, it does not rule out that there could still be some underlying cardiac or concerning issue. For your cardiac exam, very important to do a very careful and thorough cardiac exam with dynamic auscultation. So have them lay down, have them sit up, have them stand up. I also like to do a maneuver when I have them go from squatting to standing. This position, when you have them squat for a few seconds, stand up, kind of underfills your or empties your left ventricle. So for patients who have hypertrophic cardiomyopathy, this makes this murmur more prominent or makes it stand out. Any pathologic murmur, so in my opinion, any murmur that does not sound like an innocent murmur to you, if you have a gallop, a loud S2, a very loud, harsh murmur that doesn't sound, again, innocent is concerning. Any irregular beats, if they're tachycardic out of their kind of proportion to their exam or tachypnea. And while we all think about, of course, don't want to miss cardiac, don't forget to do a good neuro exam since, again, outside of cardiac, neurology is kind of the more other dangerous thing that we don't want to miss. So a quick talk about neurocardiogenic syncope since this is the most common cause. And again, in my opinion, I'm trying to make sure a patient has this. If not, then something is unusual or off. So neurocardiogenic syncope, again, many different names. Basically, there's a episode where there's poor perfusion or not enough blood flow to someone's brain. It's secondary to a transient reflex failure of your peripheral vascular system and relatively slow heart rate than what it should be. These patients have pretty classical symptoms before it happens. They were standing for a long time, specifically leg locked, like in church, band, choir. They recently changed position. They went from watching TV for a while to standing up, getting up from bed in the morning. Sometimes stress triggers these physical or emotional. They describe pretty classic prodrome signs. They felt nauseous, sweaty, clammy. Their vision was going blurry. Their hearing sounded muffled. And when they do pass out, it usually is short-lived. It's usually a few seconds. And when they come to, they have minimal residual symptoms. They might sometimes feel fatigued, a little weak, headache, but they'll remember exactly where they are, who they are, what they felt beforehand. Similar mechanism is these interesting situational, what we say is reflex syncope, more common in young adults, but again, definitely can be seen in teenagers. So, did it happen during using the bathroom, urinating or stooling? Doing a very big stretch sometimes triggers this mechanism. Hair combing when it's aggressive or someone's having their hair braided, drinking cold liquids. Blood draw is very common where the sight of blood, something noxious, sets up this mechanism that causes you to have poor perfusion to your brain. I'm not going to go into the details of this because this is a very complex kind of mechanism to understand, and we fully don't understand it very well ourselves, but during these positional changes, these specific situations, something is happening to the signals to the heart and brain where it causes your vasodilation instead of vasoconstricting when you're standing to be slow, and your heart rate doesn't respond appropriately, and you get a combination of kind of not appropriate heart rate and not enough blood flow going to the brain that causes you to pass out. Again, this is a complex talk that we can have a whole full day about, but we'll just wanted to kind of mention that quickly. So the cardiac causes, what do we have to worry about? So when it's a cardiac cause, the mechanism is going to be low cardiac output, not enough heart being pumped to your brain. So mechanical is one way where there's just physically not enough blood going out of the heart. So structural, where there's an obstruction, the left side of the most common ones are hypertrophic cardiomyopathy and aortic stenosis. And we'll come back to all these specifically. Right-sided pulmonary hypertension, you have such tight pulmonary vasculature that there's not enough blood going to your lungs, in return, not enough coming back to your left lung and low cardiac output. Is there concern for dysfunction, myocarditis, where your heart is just not pumping enough blood? And coronary abnormalities, where there's obstruction to your coronaries, providing blood to an aspect of your heart. Electrical, is your heart too fast or too slow, where it's not pumping enough blood due to it? If it's too fast, it's just not giving enough output. So the most common or dangerous ones are ventricular tachycardia or ventricular fibrillation. We'll come back to these episodes again, but the most concerning ones, kind of from a family history also, is arrhythmogenic RV cardiomyopathy, catecholaminergic polymorphic VT, long QT syndrome, Brugada syndrome. Now, I've listed it here, but supraventricular tachycardia in someone who has a structurally normal two-ventricle heart is very rare. I'm not saying it's not impossible, but it's very rare to cause syncope. It is still possible, which I've listed it. Electrical, in addition to too fast, it's just too slow. It's not providing enough heartbeats to give blood to your brain. So sinus node dysfunction and someone who has high rate or complete AV block. We'll come back again to these episodes too. So in our practice, ECG, I think, is a good standard routine test that should be obtained. Studies have shown that they might not be cost effective, but also we've seen that there's been numerous episodes of hypertrophic cardiomyopathy or long QT that have been picked up by ECG. What is an ECG useful for? It's good for your rhythm, your conduction, your intervals, your PR interval, first degree heart block, your QT interval, are you having extra beats? Also helpful if you have signs of inflammation, myopericarditis, strains such as hypertrophic cardiomyopathy or aortic stenosis. It is not good for defining anatomy, so if you have an anomalous origin of the right coronary artery, it's not very helpful for that. Everyone's practice is different, but most people, when they do an ECG, are referring them to a pediatric hospital outpatient site. Not to say you can't do it in your office, but if you do, you need to make sure that whoever is doing it is appropriately trained in placing the leads in the correct positions. Inappropriate lead placement can, of course, lead to inaccurate reads. And the ECG should be read by a pediatric cardiologist or someone who has experience interpreting pediatric ECGs. Many times the manual reads are not correct, and more scary is that patients who do have abnormal findings are read as normal. Important for you to be comfortable to differentiate between normal variants with its pathologic findings, early repolarization, RSR prime can be normal findings. And also in athletes, many athletes at high levels have conditioning or different remodeling of their heart muscle, so their ECGs might not look normal. They might show possible LVH, possible left atrial enlargement, and these might be common findings in athletes. So not to inappropriately restrict athletes who might have normal findings. So the red flags, of course, are long QT in males, typically more than 50, in females greater than 460. Short QT is rare, but an entity out there. Will Parkinson White, high-grade heart block, ectopy, true signs of RVH, Brugada pattern, cardiomyopathy pattern, and then low voltage QRS, such as in myocarditis. ECG won't help you diagnose unless arrhythmia unless you're in it, but it will give you clues in certain dangerous entities like long QT syndrome, Brugada, that might say that someone is at risk for developing ventricular arrhythmias. Classic ECG for WPW, we can see to the right, they have a short PR interval, that classic delta wave in prolonged QRS compared to a normal ECG. If someone has a history of long QT syndrome, again, yes, their ECG will be supportive in most of the cases. Their history will be consistent of syncope with loud noise, something that startled them, and a lot of times they'll have a positive family of sudden or unexplained death. I'm not going to go too much into Brugada syndrome and arrhythmogenic RV cardiomyopathy because they are complex, even in cardiology, very rare entities. But again, an ECG will be helpful in diagnosing these a lot of the times. they will have their history is going to be consistent with something that is not consistent with neurocardiogenic syncope. So if you have ruled that out, then it should be in a way a red flag. And a lot of times they'll have a family history of sudden unexplained death. CPVT, catecholaminergic polymorphic VT or ventricular attack, is a very interesting where an adrenergic state, so something that increases their heart rate, whether it's exercise or emotional, that fight or flight causes them at higher heart rates to go into arrhythmias. So these patients will have a history of exertional syncope. Many times they will have a positive family history. Their baseline ECG will be normal, but again, if we're suspicious for this, cardiologists will refer them for an exercise test where it will induce the arrhythmia at higher heart rates. So on the other aspect of very fast heart rates, we've discussed if your heart rate is very slow, it's not going to provide enough cardiac output. Sinus node dysfunction in someone who has a structurally normal heart, I would say, is very rare. It's more for someone who has cardiac surgery. High grade or complete AV block, again, these patients will have an ECG finding, they'll be supportive. And their history, this is classically seen in rheumatic fever, myocarditis, Lyme disease. So was there a recent fever? Did you have exposure to possible ticks, camping? Was there a recent sore throat, joint pain, joint swelling? This is an ECG, again, classic for third degree heart block, where you can see the P waves marching out. Now, cardiac syncope, again, it's going to be an obstruction. For hypertrophic and aortic stenosis, these kids will have exertional syncope or chest pain. Their exams will have a very prominent systolic murmur. With hypertrophic cardiomyopathy, again, when you have them do that squatting to standing, it will make that murmur more prominent or louder. And many times they'll have an abnormal ECG. This is an ECG in patient with hypertrophic cardiomyopathy. You can see that significant voltages, ST segment changes, key waves. Coronary abnormalities, anomalous origin, many times their history will only be exertional chest pain or syncope. Otherwise, they'll have a normal exam, ECG, family history. Dysfunction myocarditis, if someone had a recent fever, they're tachycardic on exam, they have a gallop, that's concerning. And again, their ECG will have classic findings of low voltage QRS ST changes. And pulmonary hypertension, rare, but again, these patients will have an abnormal exam, loud S2. They'll have ECG findings that are concerning for RVH. Now, while everyone thinks about cardiac first, it's very important not to forget about other causes. If the story is concerning or the exam is concerning for neuro, please refer to obviously a neurologist or consider advanced imaging. If something doesn't make sense, instead of having the classic preceding dizziness or vision change, they had an aura. After the episode, they had a true post-ictal state. They didn't know who they were. They slept the whole day. They were out of it. They had incontinence. The duration was longer. Again, neurocardiogenic syncope, most patients come to after a few seconds. If it's rarely more than a minute. If it's something unusual, do think about other causes. Just because of having abnormal movements, tonic-clonic movements, posturing, this can be seen in benign syncope since it is because of there is cerebral hypoperfusion. So this doesn't always mean that it's a neurological cause. I am almost done here. Is there data to support this? So this study looked at patients seen in cardiology clinic, about 480 patients, and using what we discussed, a screening tool, if there's a positive in their history, family history, exam, ECG, they were able to identify 21 out of 22 patients that had a cardiac etiology. And when there was no red flag, doing a random echo did not contribute to any cardiac diagnosis in these patients. In appropriate testing, if there is not a red flag in what we have discussed, it is not useful to do an echo in a patient, or specifically if everything is normal and you suspect vasovagal or neurocardiogenic syncope. Many times we think we're reassuring ourselves or the patient or the family by doing additional testing, but I've actually found this to be the opposite. Many times it causes more stress. They really think that there is something wrong since my doctor is ordering an extra test. And many times we come back with these insignificant findings of PFO, mild mitral regurgitation, that has no clinical significance, but causes more stress and worry. So the goal of evaluation would be to confirm neurocardiogenic syncope, since that is the most common cause. And if not, then using one of our red flags to make sure we're not missing something that has a serious underlying dangerous comorbidity. Having orthostasis is supportive of neurocardiogenic syncope, but it does not exclude more serious etiology. So if there's a red flag in their family history exam, please make sure that they are appropriately referred. So doing a careful history, again, to summarize this, I think is very important. A careful history, a dynamic physical exam, an ECG, having a sound understanding of what causes pediatric syncope and knowing the red flags will identify the vast majority of serious cardiac pathology from more benign ones. Now to go over our cases, so this first patient who had syncope 1 in the morning shower and standing up with preceding symptoms sounds classic with neurocardiogenic syncope, so reassurance. This patient who passed out while running the mile in 2 times while doing suicides while he tried to attribute it to, not drinking enough water, and hot day in the middle of activity exercise is always a red flag and concerning, and I would be more cautious and have them evaluated. So I would have this patient be seen in cardiology clinic to make sure we are not missing an anomalous origin of the coronary artery or hypertrophic cardiomyopathy. The male that passed out after cross-country practice, again, this is less concerning as long as there's no red flags. After running a race, your blood vessels are dilated. If you don't cool down appropriately, you'll get a sudden pooling of that blood and poor cerebral hyperperfusion, which can cause similar symptoms to neurocardiogenic syncope. And then the last patient, for this patient who had numerous episodes, this is likely factitious, psychogenic. It doesn't make sense. I mean, due to their mechanism, she'd either be dead or have serious injury. So detailing or diving more into it, there's some underlying psychiatric conditions on that. Thank you, and I do apologize if that went a little bit long. I'll be happy to take questions.
Thank you, Dr. Sedaghat. That was an excellent presentation. I think we all learned some great things about doing the exam, especially at a primary care setting. And I wanted to see if there were any questions from anybody. We can certainly open up the floor and entertain any questions if there are any. I did actually have a question for the, since you went over your case studies, and most of those patients were adolescent or teenage, and I wanted to know if that, do you ever see syncope show up in younger children?
No, definitely. And again, this talk was kind of more geared toward older adolescent, where neurocardiogenic syncope for kids above 10 years and older is going to be the most common cause. It is less likely if someone is under 10 or specifically under 6, not to say that can't be the cause, but I would have more cautious or worry that there is something more underlying going. So, under 6, definitely, I would say it'd be very unlikely to have neurocardiogenic syncope. Between 6 to 10, still possible, but less likely. But again, kind of this talk, I would say, I should have said, is more geared kind of 10 and above adolescents.
Okay. Thank you. And then also, since telemedicine is starting to be integrated as part of normal clinic, are you able to see any of these patients through any telemedicine consults?
We definitely can. Cardiology is a little bit tricky because number one, exam is very important. So having my own exam findings, but not to say we can't triage them and kind of guide them from there. A lot of times if we feel that an echo is needed, we still have the luxury of being able to do it in clinic. But we are tailoring it with telemedicine is becoming more often used. So having that initial telemedicine visit is possible, where if there are red flags where we know someone is going to need an echo, we can do that prior to it. But again, I think with cardiology, between the exam and doing the echo in clinic, there are still benefits to be seen first, especially for a first-time patient.
Sounds good. Thank you. I don't see any other questions showing up at this time. We do have Dr. Sedaghat's contact information. He's available through email, through Epic InBasket, Rapid Connect, and then also calling the division directly at 227-4100. So I would like to thank everybody for joining us today, and also want to remind everybody we do have another session at 12:30 today where Dr. Linder and his nurse practitioner will be discussing POTS, and then we also have 2 sessions tomorrow. So thank you for joining us, everyone, and please let us know if there's anything that physician services can do. Enjoy your day. Thank you.
Thank you.